This is Professor Joe Del Russo of Montclair State University's Center for Child Advocacy. Today I have a very special guest with me. His name is Martin Finkel. He's a medical doctor and the director of the NJ CARES program in Stratford, New Jersey. CARES is the Child Abuse Research, Education, and Service Institute. Moreover, Dr. Finkel is a professor of pediatrics at the University of Medicine and Dentistry of New Jersey, and he helped spearhead the RDTC movement in New Jersey by ushering that concept through our legislature. And for those of you who don't know, the RDTC stands for Regional Diagnostic and Treatment Centers. And these are places that kids get evaluated and treated, and there are 4 of them in New Jersey. There's one in Bergen County, one in Essex County, one in Middlesex County, and of course Dr. Finkel's Center down in Stratford, which is in Camden County. A very important part of our response to child maltreatment in this state. And another of Dr. Finkel's accomplishments include the textbook, Medical Evaluation of Child Sexual Abuse, a Practical Guide. Now, this is the standard textbook in the field. In fact, the most recent version of it was published in February 2009. You can get it on Amazon, and it's published by the American Academy of Pediatrics. How you doing, Martin?
Fine, thank you.
I wanted to talk a little bit about the frequency of findings of child sexual abuse. And when I first began prosecuting child sexual abuse cases, one of the articles that we often referred to was an article by Adams and colleagues called "It's Normal to be Normal." And one of the interesting findings in that article was out of 236 perpetrator conviction cases, there were only medical findings that were abnormal in 14% of those cases. What else was nice about that article was it had a snappy title, "It's Normal to be Normal," and it really connected with people, and every now and then we're able to mention it in front of juries, and certainly it's easy to understand what we're talking about. That's been the consistent findings, I believe, within the research for decades now, and a more recent evaluation of the findings in suspected cases of child sexual abuse was published in 2002 in Child Abuse and Neglect, and that was Hager and colleagues. And there they concluded, among other things, that even when the history of abuse is severe, where there was vaginal or anal penetration, the findings were 5.5%. Dr. Finkel, what are some of the reasons for the dearth of findings where there is even severe abuse in children?
Well, let me first just say that if you go back and look at the medical literature on the frequency of physical findings in children who experience sexual abuse, it's quite variable. In the early days, you would see literature that spoke up findings up into the 60 to 80% range. And over the years, we become, of course, more knowledgeable and skilled in terms of our examination and interpreting anogenital findings. And ultimately, we, through large case studies and clinical practice, discovered that the truth of the matter is that most kids are not going to have a diagnostic residual to the contact. And just as my colleague Joyce published Normal to be Normal, there are several good reasons for that. And I actually don't ever use the word normal. The problem I have with the word normal is that a child who is described as having a normal examination and has been sexually abused can be interpreted as, well, this is no different than a child who never experienced anything inappropriate, when in fact it is different. The substitute language that I use for normal, in meaning that there's no findings, is that the examination does not demonstrate any acute or chronic residual to the alleged sexual contact, nor would be anticipated to in light of the history provided. And that's very different because it helps explain in great part why there may not be findings. Now, if you're looking at the frequency of evidence in cases of child sexual abuse, there's clearly physical evidence. There is which would be genital trauma, anal trauma, or extragenital trauma. There can be sexually transmitted diseases. There can be quote-unquote forensic evidence in the form of seminal products, saliva, trace elements, and things like that. But actually, the most available form of evidence in any case of child sexual abuse is actually what the child has to say, and it's the medical history. It is the idiosyncratic details of a child's experience that really speak to the reality of the event. Now, we frequently hear children referred to as being sexually assaulted, and I think it's important to understand that sexual abuse of children is very different than sexual assault. And sexual assault, or the rape model, is a use of force and restraint to engage the individual in the sexual act. Very few children are ever sexually assaulted, and force and restraint are not the operative mechanism for engaging the child. Children are engaged in sexual activities generally by someone who they know, who they love, who they trust, and actually have little intent to cause any physical harm to the child because they want to repeat the activities over time. And so the operative words, instead of force and restraint, are coercion, deceit, enticement, bribery, intimidation, the kinds of things that engage kids in these activities and keep in these activities over time, then maintained through threats. So force and restraint is very infrequent. In fact, the easiest cases to give a diagnostic opinion on are children who present with acute or significant healed genital or anal or extragenital trauma. So in addition, if most perpetrators don't intend to harm the child, occasionally they will be harmed. And if they're harmed, most of the injuries that children incur are going to be superficial, just like every one of us. Throughout life, every one of us is going to fall, and we're going to scrape our knees and elbows, and those injuries are going to hurt. There may be bleeding with it. But if we look at our knees and elbows a week or 2 weeks later, we see that they're perfectly healed and they look lovely. Well, in the same way, most injuries that kids incur are superficial, and because kids don't usually tell until long after the last event when they feel safe, the injuries, even if they had bleeding, are going to heal without any diagnostic residual. Now, a smaller percentage of kids are going to, in fact, have diagnostic findings that are healed, such as lacerations that result in a complete transection of the hymenal membrane, or lacerations to the tissues that result in the formation of scar tissue. And we all know that occasionally we get injuries that are so serious that they do form scars, and we probably can look to parts of our body and see something that we incurred as an injury maybe 20 years ago. It doesn't go away. In the same way, we see these kinds of things in genital anal tissues, but far less frequently.
So part of the reason that there aren't frequent signs of genital injury or findings in child sexual abuse cases is that people have the misperception that these kinds of offenses are highly intrusive, that they're likely to produce injury, that they involve invasive attacks. And that's why I imagine the average person, contrary to what we in the profession understand, expects that there ought to be findings. That's based upon a flawed starting point. That is, that these are highly invasive acts, and they're not. They're incremental. They tend to involve grooming and touching, seduction, rather than the kinds of penetrations that laypersons expect.
Right.
And when there is injury, it tends to be superficial in nature, more quickly healing than one would expect with the kind of direct injury from a rape or penetrating assault.
You know, the activities that particularly prepubertal children, so a child who's not yet began having their menses, individuals who engage these kids in activities tend to engage them in activities that are grooming, as you said, more age appropriate. So there may be genital fondling, genital-to-genital contact, but the genitalia, the penis, is placed between the labia. There's no attempt to place the penis inside the vagina. In the adult sense of penetration, there may be reciprocal orogenital kinds of activities. These activities, many times, particularly for young children, are represented in a very loving and playful context, and represented as something as maybe very special to the child. I mean, that's why we no longer talk about good or bad touches. We talk about what's okay and what's not okay. In fact, if you think of sexual victimization, one of the hallmarks is that it could be considered the misrepresentation of moral standards to children. Where do children learn what's morally right, morally wrong? But from their caretaker. So if a caretaker explains to a child that this is the way that all dads show that they love their children, how's a child to know that it's otherwise? And many times kids are very excited about the special interactions that they may be having. So there's a lot of things that are really, I would say, counterintuitive about sexual victimization of children. It's a very, very different phenomenon than than rape. I mean, if you took all that you knew about rape and you just discarded it, it really wouldn't handicap you in terms of learning to deal with the issue of sexual abuse, because it's a different set of dynamics. It has a very, and I'm sure there are a set of dynamics, of course, in rape, which are pretty consistent, but sexual victimization involves, access, opportunity, usually someone the kid knows and has routine access with. Then there's sexual interaction that progresses over time. And again, one of the reasons that there's no intent to harm the child is they want to make sure that this is something, in fact, little kids who experience pain associated with the initial first sexual contact, frequently they don't want to play that game again because it caused them discomfort. So they'll go to great ends to reduce the potential for physical discomfort. Once the child is engaged in some form of sexual interaction, regardless of age, the responsibility of the perpetrator is to engage secrecy, because secrecy removes accountability. And actually, unfortunately, children love secrets. And, one of the things we need to do is teach children that there are no secrets. Secrets are never okay. And kids keep these secrets because of maybe it's special or they're rewarded in some way, but they also keep these secrets because they're embarrassed or afraid or threatened of consequences. So most of the acts that children experience are not physically invasive, but they are always psychologically intrusive and have potential for very significant long-term consequences. And even the injuries that children do incur, those injuries are going to heal, and the primary impact of whatever they experience is still psychological.
Indeed. What was most interesting to me about the article from 1994, and then looking at the 2002 article and some of the other research in this area, was that the conclusion seemed to be pretty much the same. Probably the same since you first began investigating this area of medicine back in 1989 or so. And that is that we overemphasize technology, professional experience, and clinical impressions, rather than listening to what the child has to say about their bodies. 15 years ago, Normal to be Normal also concluded that more emphasis should be placed upon documenting the child's description. And in the 2002 study from Hager and colleagues, their conclusion was very similar. History from the child remains the single most important diagnostic feature in coming to the conclusion that a child has been sexually abused. Again, this is inconsistent with the lay perspective, the average person's perspective, that the doctor has some sort of technology or litmus test for determining abuse, when it is of far greater importance to listen to what that child has to say about their bodies. I was looking at the article you co-authored, Girls Who Disclose Sexual Abuse, Urogenital Symptoms and Signs After Genital Contact. And that makes the point most effectively. And if I'm getting your conclusion right, I believe you are suggesting that when you listen to the complaints of female children about how their body feels, what their symptoms are, when we listen to what they have to say about these symptoms, this can give us great insight into the possibility of abuse and possibly be corroborative of the disclosure in ways sometimes more meaningful than technology.
Absolutely. In fact, what we found in our study was that if you say that on average 5% of kids are going to have physical findings that alone are diagnostic, by simply knowing how to take a medical history from a child, 37% of the girls in this study complained about the symptom of dysuria, which is a medical term for burning with urination, that was temporally, meaning in time, related to the specific sexual contact, with no alternative way of the child knowing about that symptom unless they experienced it. And so when kids experience dysuria that is related to the sexual contact, it reflects a history of trauma to the tissues around the urethra. And so when they go to the bathroom afterwards, they burn. They frequently describe it as a burning sensation with the contact. And the injuries that those kids incur, for the most part, as previously said, are going to be superficial. So when we see those children who disclose maybe a week, 2 weeks, months, 6 months later, years later, they tell us about that symptom. And they remember it. And it's amazing how many children who may have not had something happen for years remember the very salient details about that sexual contact, even in a very vivid sense. And many of these kids have symptoms of post-traumatic stress disorder, so they're replaying those experiences in their mind and they tell us about the discomfort. And it's not actually surprising what we published, because in the adult literature, in adult women, there is a phenomenon that's been well known and described, which is called honeymoon cystitis. And so that these are women who, following first intercourse, presumably on their honeymoon, had pain with urination afterwards because of the trauma that occurred during coitus. Well, in children, it's a very similar phenomenon without genital contact, just simply genital fondling, causing trauma to the tissues, or even genital-to-genital contact that does not necessarily penetrate into the vagina, but penetrates between the labia and what we call vulvar coitus, causing trauma to the tissues around the urethra. Now, so why is it so hard then to, why don't we have more cases in which there seem to be this prevalence of the signs and symptoms? In great part, it's because the hardest thing for doctors to do is to talk to kids. And these are the kinds of details that they're not going to tell an investigator or tell a social worker or tell their mom. They're the kinds of things that they tell a doctor. And so my sort of commentary on the paper, I can tell you, because you're a doctor, it really talks to a difference in the kind of quantitative and qualitative information that children will share with doctors if a doctor is comfortable. And again, that's a big if, because it's really, doctors for the most part don't even feel comfortable teaching children the appropriate names for their private parts, don't feel comfortable doing genital examination, and so they're far less comfortable being able to engage in the child in a dialogue that is not leading, not suggestible, and it gets these idiosyncratic details from children.
So I think the lesson is at least twofold. One is that forensic interviewers and people who talk to children and evaluate their credibility need to be sensitized to the fact that some of this symptomology can be corroborative of a child's abuse. And we ought to look at the history for these very informative symptoms as well as the very specific findings of genital trauma. And the other thing that I think is equally important is that doctors and pediatricians need to know not only to ask the right kinds of questions and not only to listen to kids' statements about their bodies, but to know what to listen for. Does that make sense?
Absolutely. It starts with knowing what to ask, knowing how to ask it, but knowing how to ask it in a way that is not leading, not suggestive, but facilitating, empathetic, and knowing how to document what that child said. So that these are not sort of independent recollections, but these are verbatim records of the child's specific answers to very specific questions. And, many people who take histories from children, unfortunately, ask very direct and pointed questions. I always tell our residents and students that it's really the patient who knows the story. It's not the doctor. The doctor is there simply to facilitate the patient telling the story. And when the patient tells you their story, known only to them, and you let them talk, you will fully understand what that person experienced. But if you make a presumption and ask very rapid-fire, truncated, direct kinds of questions, you will get a very limited view. You will not get the idiosyncratic details that speak to the reality of that child's experience.
Well, doctor, it's certainly clear that the patient's history is critical and often not emphasized enough, with too much emphasis being placed upon the physical examination. Nevertheless, I'd like to talk a little bit more about the physical examination so we can get a sense of what it's like to be a small child who may have been sexually abused and have to visit a pediatrician's office who specializes in treatment and forensics. How do you go about minimizing the potential for trauma when you have a small child who requires a medical exam?
So let me just correct you. I'm a pediatrician. I don't do forensics. Children come to me for the purpose of diagnosis and treatment. There may be forensic value to what I do, but that's not the purpose of why I see children. This examination, when done correctly by someone who is knowledgeable and skilled, in fact should be therapeutic for the child. It is the very first step, in my view, to helping the child put this experience behind them. Because I tell kids that the purpose of this examination is to help them with any worries or questions or concerns that they may have about their body because of what they've experienced. And children have some very unique worries about their body. I mean, children will frequently think that people can tell that things have happened to them when they look at them. Children are worried that they may not be able to have children when they're older. One little girl wanted to know if she was going to get breast cancer because he put his mouth on her breast. And so this examination serves really two purposes. And this is also the justification for why every child for which there's investigation of the possibility of child sexual abuse deserves a medical evaluation. The two purposes are for normality or physical intactness, to address those, as I said before, idiosyncratic concerns that children have about their body, their sense of physical intactness. And then secondarily, for the issue of abnormality, or what we call residual to the contact. So that would be for diagnosing and treating injuries, whether they're acute or chronic, for sexually transmitted diseases, and of course for collecting trace elements if there should be those kinds of things. But because most of these kids are going to present long after the last contact, because it's really the disclosure that precipitates the crisis, we see these kids, mostly kids are not going to present with acute kinds of injuries. They're going to present with a statement or behavior that raise the concern that something inappropriate happened.
Dr. Finkel, when the medical exam is being conducted with a child, do you permit the parent or the caregiver in the room while the examination is being conducted?
This examination is done to help this child understand their experience, to express their experience. We take a history independently with the child, and that's a rapport developing process so that I can set the stage for the child to share their worries, their concerns. I gather information to the child, I share information with the child, and that rapport building session helps to set the stage for the physical examination. And the child always has a choice as to who they want in the room. Now, young children obviously are going to request their caretaker to be in the room, whether it's a mom or grandmom or whoever it is. Sometimes adolescents prefer not to have their parent in the room for privacy issues. And the examination in children who are not pubertal yet, meaning that they've not had their menses, is different than children who are pubertal. So in the prepubertal child, there's no use of any instrumentation. So it's not an adult gynecologic exam as any adult woman would think of that examination. There's no use of instrumentation. Occasionally cultures and things or swabs may be placed through the hymenal opening into the vagina, but if that's done skillfully, the child doesn't even know that you've touched them. The other thing, and I was the first to introduce the use of video colposcopy in the United States, and basically what that does is it takes an adult gynecologic tool, which is nothing more than a fancy magnifying glass and light that's used to look at the cervix to diagnose cancer, hooked up to a video, and actually the child can watch the examination on the TV monitor. So for the little kids, let's say a 3-year-old, I may have them blow the light out as if it's a candle. A 4-year-old, I might show them their belly button on TV or the fingernails on TV if they've done their, have nail polish on. And so I take whatever time is necessary to make the child feel comfortable. I demystify the examination process for the child. In fact, the ability of the child to watch the examination on the television monitor actually does demystify the exam. So a child will be laying, and little kids, I tell them to, sit like my friend Kermit the Frog does when he comes to have his private parts looked at. And so I will say, you're going to see my hand coming closer to you, and now you're going to feel me touch you. So they're watching the TV, and I'm watching the TV, and I'm also watching them. So if I see that the child gets a little tear welling up or the lip quivers, I can stop, I can talk, I can engage them, I can address their fears and anxieties. And so this examination is not something that is quote-unquote traumatic to the child. If done correctly, this child will find it valuable. And so that I can walk away and I can say to the child afterward, I looked at you from head to toe and you saw I looked very, very carefully. And you know what? Your body is okay and nobody can tell that that stuff happened to you. And so we can put, any worries or concerns about their body behind them. The little ones may not have any worries or concerns, but again, the manner in which I engage the child in conversation, show them on the television, it's absolutely amazing. Parents frequently say they'll never let you do X, Y, or Z, and it's absolutely amazing that 95% of the time kids have no problem with it. Now, clearly there are kids. I would say that having your genitalia examined is no one's favorite thing to do. But there are ways in which it can be explained and done with sensitivity, using patience and time, that you can make it as comfortable as possible and a valuable experience for the child. And the same goes for the adolescent. In the adolescent, depending upon the specific history, there may or may not be the need to do a speculum examination. Yet, there are adolescents who clearly will require a speculum exam to take specimens from the cervix and to get internal visualization. But most of the injuries, if kids incur injuries, are going to be on the outside. Most of the injuries are not going to be deep into the vagina. Occasionally we have maybe once or twice a year out of the 900 cases we see of sexual abuse a year, we would have one or two who have to have an examination under anesthesia because they have very serious genital or anal trauma that require potentially surgical repair. But under most circumstances, it's really a matter of external visualization. In the adolescent, it occasionally involves the use of a speculum, which is closer to the adult gynecologic exam. And again, we take whatever time is necessary. We'll have the child touch the speculum so they feel what it is. We explain everything. They can watch on the TV to see. So this examination is designed to be part of the healing process.
So this is another area of medicine in the sexually abused child that may be misperceived by the average person. I would suggest that the average person thinks that this is a highly anxious, highly traumatic experience for the child, that it's very difficult and that overall it has a negative impact. But you're suggesting that when done right, this can be a very positive experience for a child, that it can begin not only the physical healing process, if it's even necessary, but the psychological healing process. And the medical exam, if done by a sensitive, caring, and thorough physician who's well trained, can be something that a child walks out of feeling better about themselves rather than anxious or upset.
Absolutely. As I said, we see kids to help them. They've already been through enough trauma. The last thing we want to do is to add to their trauma. I began to say, but didn't finish, is occasionally there are children who are emotionally not ready for the examination. And so you take it in steps. And you explain to a child, usually many times it's older kids, and you explain to them why you think the examination can in fact be helpful to them. But when they're emotionally ready, then they come back, and we can do it at that time. You don't hold a kid down, you don't force them, you don't coerce them, you don't deceive them. Remember, their sexual victimization is not something that they were given a choice about. So part of the recovery process is to give kids choices.
Right, sure.
And one of the choices is to have the exam or not to have the examination. But again, if you don't understand, if the doctor really doesn't understand the whole phenomenon of sexual victimization, what I like to refer to as the disease of sexual victimization, they're not going to just spontaneously have this kind of knowledge and sensitivity to approach the child in the way that they need to be approached. Now, one of the things that we do is I have a little brochure called Frequently Asked Questions. And so it has all those common fears and anxieties that parents might have, and parents transfer their fear and anxieties to their children. So the more that we can do to reduce parental fears and anxieties, they're going to be confident. They're going to transmit that confidence to their child. They're going to encourage to their child, and children do well. And so it's important for professionals to understand what I've told you, because it's not uncommon for a caseworker to say, are you sure you want your child to have to go through that kind of a thing? Well, that's simply because, or someone from law enforcement may say, anyone who's not knowledgeable what it does is going to give the wrong information. And that examination can have great value for the child, and it should.
Absolutely. You mentioned a little while ago that you introduced the video colposcope. Tell me a little bit about colposcopy, what its utility is, and whether you still use it, and in what context you use it.
Yes. Well, first of all, as I explained before, the colposcope is nothing more than a fancy light and magnifying glass. It is actually focused about a foot from the child's genitalia, so it doesn't touch the child in any way. And we shine the light on the child's genitalia, and it's hooked up to a video monitor, so if the child wants to, they can actually watch on the television. Now, the value of the colposcope is that because of the enhanced magnification, the ability to go anywhere from, and they vary from scope to scope, but generally it's 3.75, 7.5, 15, or 7.5, 15, and 30 magnification. There are various magnifications, but as a general rule, up to 25 or 30 magnification, we can look at the tissues with enhanced visualization and see sometimes very subtle things that may not have been so obvious by the naked eye. This is particularly true in children who are presenting acutely, and they may have some superficial injuries that with the naked eye may just look like irritation. But when we use what was called a red-free light, which actually the light appears green, we can enhance the appearance of blood vessels, superficial abrasions, and may be able to see mucosal injuries that were otherwise unable to be seen. The other advantage of the video colposcope is that through the colposcope, we can document the examination. I can actually record the examination on a DVD or in the old days on videotape. And so I have a permanent record of what the examination findings are. And if anyone ever challenges my opinion, let's say a defense attorney says, I challenge Dr. Finkel's opinion, I want this child examined by our expert, I can assure that that child will never have to have a repeat examination if someone challenges my opinion, because I can then present a copy of my actual examination to the defense expert. They can look at, they can see exactly what I saw, and they can challenge my opinion if they want to do that. And so there's nothing scary about this equipment. It doesn't touch the child, and it simply acts to enhance the doctor's magnification and visualization. And the truth of the matter, the interesting thing historically is that this instrument was introduced because in Brazil there was a law that said that if you got married and after your wedding night the husband believed that his new bride was not a virgin, he had a period of 2 weeks to prove that. And so the medical examiners in Brazil were scratching their heads, how are they going to do this? And one of them, Dr. Wilmes Teixeira, decided, well, maybe if I looked with magnification and used the colposcope to do that.
Well, from that cultural idiosyncrasy was born a very useful tool in identifying kids who may have been sexually abused. And to me, it's a win-win situation. It allows the clinician to have a far more sophisticated and precise view of the genitalia, and also it allows law enforcement and the legal system to use it, as you suggested a few moments ago, to share with the defense lawyer should there be an attack upon the reliability of the doctor's findings.
You know, one of the things that you haven't asked me about, but one of the things that we commonly will need to do is to address the discrepancy between a child's perception of what they actually experienced and what they experienced. I mean, and particularly that comes to the issue of penetration. Children will frequently say, he put his pee-pee in my cootie cat. What does that mean? Well, someone might say, well, they experienced vaginal penetration. That's what penetration is. Well, the truth of the matter is most prepubertal children never experience penetration into the vagina per se, but experience penetration between the labia minora into a space called the vaginal vestibule. And the word vestibule means entranceway or hallway. And so there's this mucosal surface space, just like the inside of your mouth, that is between the labia, and that's called the vaginal vestibule. And this is in front of the hymen, because the hymen is a piece of tissue that's recessed in this space and actually is the dividing line between the internal and external genital structures. So an object doesn't really get into the vagina until it has gone through the hymen orifice. And as I said, very few prepubertal children ever experience penetration into the vagina per se. So in genital fondling or oral genital contact or genital to genital contact, most of the contact is between the labia.
Yeah, that's an excellent point, and I was thinking about that before when we were talking about the frequency of medical findings, and that linguistic explanation is an important one, where the child expresses to an interviewer or to an investigator or to someone questioning them that they were penetrated or something went inside them, when in fact it in all likelihood is, as you suggested, that it was the man achieving arousal by rubbing his penis on the labia. Nevertheless, the adults misperceive that child's statement as one of rape or
Right.
actual penetration into the vagina. And that's not what's happening.
And in fact, actually, one of the things that when a child says to me, he put his pee-pee in my cootie cat, I use an anatomic model of the female genitalia that is seen in most gynecologists' offices, so adult women know about it. It's a model that the gynecologist uses to show their patients, here are the ovaries, here's the cervix, here are the internal structures. And I use that model and I show the child, here's where you pee in an age-appropriate way. So obviously when I talk to a 4-year-old, it's different than when I talk to an adolescent. But here's where you pee and this is where you poop. And when your mommy taught you, when you wipe yourself and you pee, you wipe yourself this way. When you poop, you wipe yourself, front to back so you don't get your poop into your pee-pee. So I show these things and then I say to the child, so when kids tell me that someone's put their pee-pee in their cootie cat, there are different kinds inside. Inside could be like this, like you're wiping yourself, or inside could be like this and showing inside in the adult sense of penetration. Or sometimes kids aren't really sure whether it was like this, between, or inside. What do you think? And so some kids say they're not really sure because they hadn't thought of it. Or some kids might say with bravado, they'll demonstrate inside, and it never went inside. Or sometimes kids will say it went between, and the physical examination could show that it actually did go inside. So we gather the child's perception, we do the physical examination, and then we explain the discrepancy. In the same time, we're also taking a history. So we're taking a history to find out if they had any signs or symptoms associated. Did they have any bleeding? Did they have any discomfort with urination? Sometimes kids give a history of contact with potentially infected genital secretions, ejaculation. And they give those histories in very interesting ways. I mean, one little boy, the perpetrator rubbed his penis between his buttocks. And so there are also these issues of anal penetration. And most of the anal, quote-unquote, penetration is actually between the buttocks, rubbing over the anal verge tissues, as opposed to inside the anal rectal canal itself. But this little boy, who was 5 years old, said his cousin had rubbed his penis over his tiny, and then he started to sweat on his back. And the only place he sweat was on his back, which was him ejaculating. So kids provide these sort of idiosyncratic details that also a child would have no alternative way of knowing unless they experienced it.
Well, I'll tell you this, Dr. Finkel, the children of Stratford and the area and environs around where you practice and your colleagues practice are certainly privileged to have you and your staff there, because obviously you spend a lot of time thinking about these things and making sure that the child comes first and that they're treated with respect and dignity and they get the highest standard of care. I want to change direction a little bit and talk about physical abuse just a little bit. We're pressed for time somewhat, but nevertheless, I want you to address a couple of issues involving the physical abuse of children. Can you give me a couple of examples of an injury that you might see where caregivers show up at the ER or show up at a doctor's office? They don't have an explanation for the injury, yet we really can't determine whether it was abusive or not. And we see these all too often where no one observed anything and there's an injury. Give me a couple of examples of non-specific physical injuries.
It used to be thought, people would say for years that certain kinds of fractures are what we call pathognomonic, and that's a very fancy medical term that means that when you see this, you know this happened. Well, the reality is that once we've learned and studied the biomechanics of injury, we've learned that there are very few fractures that in and of themselves speak to the mechanism that's abusive. I mean, there are some that are. So, for example, an infant who has rib fractures, rib fractures are diagnostic of child abuse. They are compression injuries, and you see healing rib fractures, you can say with certainty. Now, you can't say who did it, but you can say with certainty that these are the result of an abusive event. It used to be said that spiral fractures were in fact abusive because it meant that someone grabbed an extremity and fixated it at one point and twisted it at the other, and that was how it happened. Well, the truth of the matter is we see lots of spiral fractures where, particularly in toddlers, where a foot gets fixated and they rotate on their own weight and they end up getting a spiral fracture. And so, just like in sexual abuse, history is important. Did someone see the injury? I mean, there are injuries of the epiphysis and the ends of the bones that are the result of torsion or the result of pulling and rapid movements, buckle handle fractures and things like that, that are more specific for abusive injuries. But there are a lot of injuries themselves, fractures themselves, that on their own, without a quote-unquote scene investigation, without collaboration, cannot speak directly to whether it was inflicted or not. Then, of course, there are constellations of injuries, so that if you have a child who has multiple injuries and you have injuries, particularly of bones that are in different stages of healing, then unless they have some rare metabolic bone disease, are diagnostic of prior injury. Interestingly, a common fracture in little kids, particularly in infants, is linear skull fractures. Kids many times will roll off of a table, catapult out of a carrier, and they can get these simple linear skull fractures that on their own could very well be, and most of the time actually are accidental. In fact, there was just a recent study that looked at the utility of looking at doing skeletal surveys for infants who just have these simple linear skull fractures, and they found that none of those skeletal surveys were positive. So we look to, of course, how the child presents with an injury, what's the history, and then decide what kinds of studies we're going to do.
So there are very few fractures and very few physical injuries that in and of themselves are diagnostic of abuse.
Well, usually it's a constellation of things. I mean, clearly you can see children who have cutaneous injuries that are diagnostic.
Nevertheless, it depends upon, I guess, the injury, the stage of the child's development, any explanation, those kinds of things. I mean, you need more than the injury to draw a conclusion in many cases. In some cases, it's obvious, right?
Particularly some of the cutaneous injuries. But the most challenging cases, of course, are the little kids who can't provide a history. And one of the things that's so important is that I always tell, doctors that when you're in your office and you're seeing a child, whether you're in the emergency room or you're in your clinical office, you have a very limited worldview of what this kid's life is about. And doctors, as a general rule, are trusting and they believe and they are naive. And so if a parent tells you that their child fell down, a flight of stairs, most doctors are going to believe that history because they believe that most parents are bringing a child to them because they want their help for the child. Well, the doctor doesn't even know if stairs exist. And so, or the child fell on such and such a surface, and the doctor doesn't know if that surface exists. And so I think doctors need to do a better job of being sort of asking more probative questions, asking questions in a way that are not accusatory, but give an opportunity to try to get more contextual details as to, the chronology of the events that resulted in the child presenting to the doctor.
That's an excellent observation, Dr. Finkel, and we touched on it before. In fact, I know from our relationship over the years, you have promoted initiatives to train community-based doctors on the issues and dynamics of child sexual abuse. And it's important that these pediatricians have the interest and the access to information about these dynamics. And indeed, it's a never-ending challenge that we all need to embrace. That is, to make sure that pediatricians are up to date on all of these issues.
I think one of the things that physicians need to recognize, just like actually anyone who's going to help children or help try to understand what a child experience has been allegedly abused, is that child abuse is a puzzle. And so as any puzzle, there are many, many pieces to that puzzle. Sometimes medicine is the ordinal piece. Sometimes it's law enforcement, or maybe child protection, or maybe mental health. And it's only when we learn to work in a collaborative way that we'll really understand what a child truly experienced. When we each bring our piece of the puzzle, our knowledge, our skill, our professionalism to the table, and share that information with colleagues in law enforcement, child protection, medicine, mental health, that we will really fully understand the child's experience, know what kinds of interventions are necessary to not only substantiate, but then to protect and ultimately to treat the child who truly has been a victim of abuse.
Well, I think that's a great way to end our discussion tonight, Dr. Finkel, and I want to thank you for your time. It's really been enlightening. I often think I've reached a point where I understand much of what I do, but every time I have a conversation with you, I learn something new, and certainly something new about the medical aspects of abuse and neglect. Again, it's really been a pleasure, and I want to thank you for your time. And in closing, are there any issues or ideas that we should be aware of that we haven't touched upon this evening?
No, I have to tell you that when I had to learn about legal issues, I couldn't learn it from my medical colleagues. I learned to listen to law enforcement. And so, again, we have much to learn from each other. And again, by working together, we ultimately serve the needs of children and families. We also share the liability and the responsibility, and it can't all be on any one discipline's shoulders, that's for sure. And obviously, though I may be have some leadership role in the area of medicine, you surely have filled that niche when it comes to prosecution, and I must say you have that reputation, that's for sure.
Well, thank you for those kind words, Dr. Finkel. It's been a real privilege talking to you, and please keep up the great work that you do in New Jersey and throughout this country, and good night. You have been listening to an interview with Dr. Martin Finkel, recorded on April 19, 2009, in New Jersey, USA.